Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Joanna Richey. Hi, Joe.
Hey, Jeff, how you doing?
I'm doing great. How's your weekend?
Weekend was good, just getting ready for fall. It actually is cold again, which is lovely.
Absolutely. Our guest today is also a warm weather folks, if you will, Dr. Pulapaka from Florida. Welcome to Dean's Chat.
Hi, Jeff. Hi, Joe. How are you? And it's hot here in Florida. It was a heat wave again.
Oh, geez. It never ends. Nobody's ever really happy. My daughter says, the problem with Arizona is too hot in the summer and too cold in the winter. So
Yeah.
that's kind of how things work. Well, Dr. Pulapaka, we are very informal on Dean's Chat, and we've already kind of started going first names. I'm assuming that's fine. Jenneffer, Joe, and Jeff.
Perfect.
All
Three
right.
J's.
Three J's. There we go. We're styling. All right. Let me give you a little more formal introduction, and then we'll get lots to talk about today. So Jenneffer went to Barry University School of Podiatric Medicine. She did her residency program at Mercy Hospital in Miami. She's currently in practice in DeLand, Florida. Did I pronounce that correctly?
DeLand.
DeLand. All right. Sounds good. And she's got quite a history within our profession. So early on, you were the second female to go to Russia and be trained in Ilizarov external fixation techniques.
Correct.
Her career has taken kind of a circuitous path, one and still is. You owned a restaurant. You're an author of a new book. You are certified in lifestyle medicine. You're interested in plant-based nutrition, which, Joe, you are also. So there's a lot to unpack here. So the first thing I was going to do is ask you about your new book. Let's talk about your new book. That's how you and I got connected.
Yes. New book. It was about a 3-year project. Heart healthy, plant-based cookbook. We have over 100 recipes. We were approached by the publisher to produce a book that was no added fats and no added sodium. So we had 2 previous books before. One was Dreaming in Spice. The other one was Sinfully Vegetarian. And the Simply Vegetarian was that. It was the, everything that people say vegetarian food can be unhealthy in, and it was that. It was very decadent. But this was more in line with what we were doing in my medical practice and what we were really doing in being a lifestyle medicine practitioner. So I'm really happy to have that out. And I use that kind of as a guideline and a patient source and resource when it comes to culinary coaching with patients. So it's a little bit different twist from what a typical podiatrist would do.
Absolutely. Joe, your thoughts?
Yeah, I was wondering if just jumping off on that last point there, as you've been through, your career, seeing patients pre some of this culinary adventure that you've been on and now post, what are some of the differences that you've noticed in terms of how you manage patients, how you look at them, or even maybe some of the workup stuff that has changed?
I think when I first started my podiatry practice, it was in 2005. I finished my residency down in Miami and I went directly into private practice. So I started my practice by myself and I've maintained it all along. I was one of the first female surgical programs or offices in DeLand. It was very maternally dominated. Shortly after that, we opened up the restaurant. We had one of the top restaurants in the United States. My husband's got 3 Beard semifinalist nominations behind his back. We do shows. I was having a problem with kind of connecting the two, and I needed food as medicine really just started to make a hit. Tulane was starting to push food as medicine a little bit more. It was something that was starting to intrigue me. Was food really to be treated as medicine or as a prescription that you could give a patient? So that sent me down retraining for the most part. I'm the first podiatrist to be a physician board certified lifestyle medicine on that. And that took a lot of retraining on that, because that board was the same board that the MDs and the DOs take. And I realized that there were big gaps in my education that needed to be filled. So it was about a 2-year program that I went through in order to get up to speed with where I needed to be. And yeah, the patients changed drastically on how I would see them or handle them. Burnout, that's always brought up with lifestyle medicine. I think it was kind of very everyday, seeing the same typical patients years ago. And then when lifestyle medicine came in, burnout really went away. You went back to treating the patient. You went back to seeing them as a whole person and not just their problem in isolation. So one key factor with lifestyle medicine is traditional medicine or conventional medicine is patients are a passive recipient of care. You either have surgery or pills. That's usually the two ways we deal with our patients. And in lifestyle medicine, we're heavily evidence-based. So it's different than holistic or functional. We follow rubrics on our research that we bring in. We really look at getting top quality papers that are coming out, and those are how we apply those to our patients. What else? How do I do it? My patients are active participants, I think, is a really good way to think of it when it comes to their healthcare. And we work with my team in my office, and we really coordinate care for them. And I refer a lot. So nutritionists, nephrologists, rheumatologists, we're aggressively working with these plans of care on a patient in a more team-based approach that I really hadn't been doing previously. And then we do culinary coaching. We do small group exams. We were away. We had to do some filming at the beginning of November, and at the beginning of every month we do small group exams. So we had to miss this one, but it'll kick back in December. The topic is breakfast and roasting. So that's what I have the joy of bringing my patients in and sitting down and going through culinary coaching with them on those topics.
I have a question for you. Where do you start with culinary coaching with a patient? Because I'd like to be culinary coached. Is that a fair question?
So culinary coaching, I did take the program. That's a Harvard-based program on that. You learn your plans of care on how you want to work with the patient, how you coach them, how you're able to interact with them and have them set value statements for the way they want to move forward with their healthcare. But when it comes to training and how it would work with a patient, I usually use some of my big ones are my diabetic, my PAD patients, my patients with obesity and osteoarthritis. Those are a big group that we see. All of them have been referred out to a dietitian or a nutritionist. They'll come back in with their plans to me then afterwards. So from there, then we'll work on what does it look like and how do we construct food with them. We're doing roasting and breakfast. We've done beans and grains. We've done, I'm trying to think some of the other ones on it. Sometimes we'll start to add fitness. We're looking at different protein sources if we're going to be doing fitness with them on that side, or maintaining our protein levels. How are they, if it's a diabetic patient and they're a tricky patient that may be doing a lot of fitness, are we monitoring their blood sugar so they're not dropping off? Do we see those things? So it works differently than I think previously I would have approached patient care in general. Yeah, but we do play around with food a lot, and they're so scared of things. They're terrified of beans and grains, I swear. So those are the things that scare them the most.
When you say them, are you talking about diabetic patients?
Just patients in general.
Patients in general.
Yeah, they're scared. They get so nervous over preparing a bag of like dried beans. We get them to the point where they're able to work with that. And I keep on telling them, it's a $4 bag of beans. It's okay. You use, 1 cup. it's okay. You can let the $2 go if it didn't work out, you know?
That makes sense. That makes sense to me. Because I was thinking, I was comparing it to the patient whose idea of healthy food is to go to McDonald's with their app because it's easier. Because it's easier.
So it's not. So part of that is really working with them and training them. How do we look at beans? How many different beans can they name when we go into a class? I usually bring these all out and they're set up in the room so they get to play around with it. How do we decide to maybe take foods that are healthy and increase maybe a protein source? Maybe some of my patients are older in a group and I have to worry about sarcopenia or cachexia with them. So I'm worried about, are they getting protein like usually 3 times a day, and is it quality? And for me, quality is not, I'm plant-based with everything I tell them. I don't go with meats or dairy when we're in the discussions. And the primary reason is because usually in their lifestyle, they're already doing it. They've been knocking that out, and probably that's why they're at the point that they're at right now. So they clearly know how to use oils and salt and meats and fats. Now we're going to learn a new way to not have that in it. So that's how we work. It's different.
Joe, your thoughts?
So I'm curious, as you had mentioned a couple of diagnoses that you will commonly see, and those are a cohort that you find a lot of utility. With so much of lifestyle medicine being centered around lifestyle issues, what has been your experience in terms of there are some constraints that people are under that require pretty significant changes in their life that some people just can't do? So you talked a little bit about coaching as well. Can you talk a little bit about what that kind of experience looks like for patients where, there's not a surgery or a drug necessarily. This is a much bigger issue. How do you start that conversation with those patients?
So within lifestyle medicine, we have 6 pillars that we're going to stay with. So it's nutrition, we go into exercise and sleep. Those are my big ones. And then stress and social connections, and then abstaining from substance abuses. Social connection and stress they go fairly well together on that. And we break those up in that category. A majority of my patients aren't really dealing with substance abuse. Sometimes when we find it out in a group, when we do group exams, we do small group exams. Usually I'm with 8 to 12 patients at a time. We come in, we have our non-disclosure, and I tell them it's sort of like Vegas. What's said in the room stays in the room here. And they start to build connection and bonds with the patients in the group, both in the group and outside of the group. Let's say if we're going to work on exercise and they want to start a walking program, 2 of them may live fairly close to each other, and they'll use that to springboard off of to start a walking program themselves. When it comes to, let's see, the groups on like a diabetic patient who has a midfoot ulceration, when they say, well, I can't exercise because you told me I shouldn't be weight bearing, I get to remind them that I've got a ton of seated exercises, and we bring in, I have a yoga instructor that will come, or I have a physical therapist that will come into the group exams, and we do seated exercises. Now I do it with them, my staff does too, and I always tell them, you'll get a burn, you really will. You're really working out your legs and your upper extremity. But that's how coaching would play when they would say, no, I can't do it, I have an ulceration. And then I would say, here's a list of the exercises that I want to go through with you. Our simple thing that we usually tell our patients to do is put them down on old-fashioned index cards, write the exercises that you want. Maybe there's about 20 or 25, and you're going to pull your index card and you're going to do it until you fatigue. So pick like 5 cards a day, put them back in, and say, okay, I only could do 15 reps on that day, and write it down on the back of the card and then put them back in, only draw so many out. And that's how you start to build that up. And usually I'm always asking them where their confidence level is that they're going to be able to accomplish that. So I'd be like, Joe, so we talked about it. We went through about 4 or 5 different exercises, and I showed you, I want you to see if we can start to do about maybe 10 minutes, 3 days a week. Is that something realistically that you think you could do? What would you say? Just asking you if I was to ask you to exercise.
Okay. Yeah, I think 10 minutes 3 times a day. Is that what you
said?
3
times a week. Sorry,
3 times a week. Definitely. Yeah, very reasonable.
Okay, good. Okay, so what's your confidence on a scale of 0, never doing it, and 10, you're going to absolutely do it?
Probably an 8.
Okay. So now
Being honest.
eight's my borderline. It depends on if my patients failed at 8 before. If they failed at 8 before, I'm going to go down and I'm going to renegotiate and ask for, okay, can you name 2 days out of the week that you'll exercise? Not 3, but what about 2? What are your 2 best days?
Yeah, weekend. Okay,
the weekend. So Saturday and Sunday. So you can do Saturday and Sunday about 10 minutes a day, right?
Absolutely.
Okay. So now what's your confidence level?
That's a 10.
Okay. So that's how we kind of do that negotiation with coaching, trying to figure out where they are. Same thing with foods. If I'm asking for a substitution on foods, that's how I'd move forward with coaching with the patient. Same thing if I'm going to deal with, are you going to wear your orthotics? Are you going to be consistent in them? Are you just going to wear them when you go out in your sneakers and not in your 80% of the time in the house? How do I negotiate that? I pull that into, traditional podiatry practice in that way, but I do like coaching with the patient. I feel it gives you a better census of where it goes, and it gets charted and it gets put into their chart. We're lucky in my practice. I use AI. I use ambient AI in my practice. So I use Deep Cura. So that sits. And then when the patients, we always tell them after these big discussions, you want your progress note back, because you'll see how in depth it was on the discussion that we had.
I love this. I could see it gamified with AI so that they can measure their, for lack of a better term, compliance or their willingness to adhere to the program. Because what I heard you say, Jenneffer, is just so important for everybody. It doesn't matter what their lifestyle or health condition is at any given time. When you start talking about sleep and exercise, and you talk about what you eat, and you talk about the brain, and you talk about supplements or whatever else they're doing, I mean, that's the answer. I mean, even neurocognitive disorders, I mean, you're trying to delay the onset of chronic diseases. It makes sense to me. So kudos to you. I think it's awesome.
So like our wound care patients, sleep is a big factor. I want them to have sleep. That is their time when their growth hormones are going to kick in. They're going to be most beneficial through their sleep process because their cortisol levels drop off. So I negotiate for sleep. We have sleep hygiene handouts. I refer to sleep clinics. If they're failing with their CPAP or their BiPAP device, there's an oral application that they can put in their mouth. There's sleep dentists that are out there. So we refer our Medicare patients, it's covered underneath Medicare, off to the dentist in order to get that covered, because maybe we are having a patient who maybe is on chemotherapy. We have a wound, they're diabetic, they've got PAD. I've got slow healing. Every time they're getting a dose of their med for their chemotherapy, I'm seeing a drop off in their wound healing. So now we're going to just start to lay it on. How much can we start to improve? Where's the evidence-based literature that's out there for it? And it's pretty high when it comes to wounds and exercise with wound care too, and upper extremity. So we do upper and lower extremity with our patients with exercise.
How do you quantify things? Is it purely based on patient reporting?
Some, yes, unless they're in a program or they've started and they said they need assistance, and then we'll throw them back into physical therapy. We're usually a 2-week check, and my staff puts it on their task list. So we get the reminder and we call the patient up and we review it. If the patient says, no, I think I need more help, we bring them back in. If they need more one-on-one help, then they'll come back in with me. If they want to come back into a group, they want to go back into the group setting with the yoga instructor or the physical therapist, they'll come in and do that.
Maybe I'm not on the same exact path, but I'm kind of referencing, I have a concierge doc, right? So when I go to see him, we have baseline panels. I get heart screens sent to Cleveland Clinic. I've got ultrasounds and CT scans. So I have a baseline, right? And then when I go see him each year, we repeat that baseline. And, if I've been a good boy, I probably didn't gain any weight, and my cholesterol levels are reasonable. You know what I'm saying? All of that. I didn't know. That's what I meant by quantifying.
So almost all of my patients will get an ABI and a foot screen. Usually they're at that level.
Okay.
Most of my patients are going to have enough components that qualify them for an ABI. You know, I've got high cholesterol, hypertension, and they're probably going to have diabetes. Those are the big ones. So we do monitor a lot with ABI and foot screens. You know, we go back and we're looking for neuropathy. We actually, so instead of just saying LOPTs, loss of protective thresholds, we actually put a percentage on it, so it helps us out. So out of the 24 spots, how many couldn't you feel? This time, you know, you were at 4%. Last time you were at, you know, 54% you couldn't feel. You're improving. Where is the improvement coming? You were on metformin. You increased your Bs on that side because metformin long-term causes B12 deficiency. You know, it depends if their primary cares are monitoring their B levels. They only get it once unless they're deficient with Medicare. So we try to make sure we're not overlapping on labs, but we'll pull the labs from them and incorporate those. So we'll do some of that. Yes, we do on that side. All my patients get weighed. All of them get height, weight, temperature, blood pressure. We also do calf measurements. There's not a spot on our EMR. It becomes a waist measurement at that point in time because that's the only spot we can have to put it in. But that's a really good indicator as to whether or not we have swelling, especially with our CKD patients. So they'll get, you know, lower extremity swelling from their renal disease over time. So you start to, other than the DVTs, we just start to monitor those methodologies and weight. And they really do pay attention to weight. They really hate that when they come in. It's the same scale.
I'll bet. I can see that. All right, very good. Joe, other questions you may have?
So I looking through some of your information again in preparation for today's interview, you have a lot of certifications through wound care, various wound care agencies, and I can definitely see some of that integration between some of the lifestyle medicine, food as medicine, nutrition we know is so important when it comes to wound healing. What have you seen in terms of some of the biggest gains for your patients in terms of how they kind of take some of this culinary coaching or lifestyle medicine? What has that integration in your practice kind of looked like for your patient care?
I think they use us as a springboard to balance out with their other specialists. So when we get our wound care patients who have vascular disease, we usually are coordinating the care for the vascular surgeons that we send off or the interventional cardiologists that we send off. And we stay in contact through the whole process, whether it's me discussing it with the cardiologist, what procedures we're going to move forward with, what medications do we want to change, you know, are they having claudication? No, they're not having claudication, but it's an asymptomatic vascular disease. We start to move that way. We'll find, oh, you know, your renal function, you know, your EGFR, you said you didn't have kidney disease. And now, you know, your EGFR is sitting somewhere at like, you know, 42. Did you know it was that low? No, I didn't. But they're already seeing a primary care doctor. So we're rounding them back to go back to the primary care doctor. You need to have a discussion with your primary care doctor. So that's what I think we've been able to utilize with patient care is getting patients back to their specialists and making sure they understand it. I get quite a few patients who will go out there and they'll see them and they want to have an appointment back with me to discuss everything that was there because they're concerned about their body. You know, my knees are killing me, and I went off and I saw the orthopedic surgeon. They said to do this, and I'm just really confused. You know, that's in. So everything, it's always in my scope of practice that I'm dealing with, but I just find patient care, they're really lost when it comes to the quality of time they get to spend with their other providers. And we just now have a good handle on how we handle it. And we're time-based with Medicare on how we bill. And then on small group exams, everybody's together during the small group exam when we're doing time-based E&Ms.
Interesting. You know, I'm thinking, Joe, of Upperline Health with their accountable care organization, and they were putting podiatrists as the center and then bringing in primary care services because all that data supports the patients don't necessarily go to see their primary care, but they love to go see their specialist. So if they have a diabetic foot ulcer, they're coming to your office on a weekly basis and they're getting it taken care of. They're compliant with those visits. But when it comes to just routine visits with the PCP, sometimes that compliance issue isn't there. So I can certainly see where you're coming from for working to get that multidisciplinary team on the same page. Very good.
We do have a lot of fun. We have a lot of fun in the office. It's always interesting when we do the group exams to see what dynamics come out in them. Recently, we know within our community there's a problem with good support, I think, for my patients who have had losses of family members. So we've been hearing that a lot. So our office now, over the 6 months we have planned, we've looked at it, and we're going to start a walk with the doc program in our area. Because I'm having my patients tell me I've lost my spouse, and I'm seeing them socially distance themselves. When we start asking questions, patients ask me all the time, why do you ask questions like that? You know, what are your social connections? You know, do you go to church? Do you participate in a club? You know, they're always wondering why we ask that. But so we're doing walk with the doc. Not to be morbid, we have a cemetery, a historic cemetery that's right by us. But the new part of the cemetery is very flat. The old part, I've got some nice elevation that we can walk and we can get around in. So it's a really nice place to move, and it's shaded, and it's a safe environment for my patients. And we've decided we're going to work with the Historic Society so that they will do recordings as we can go throughout of grave markers for a lot of the historical people in the cemetery. And that can be like a little mini break while some of the patients can walk, or some of them are going to go from point A to point B, which is a very short distance. Other ones are going to try to walk faster in between, and then we'll have a moment of stop. And we're going to try to tie these themes in with a book club for that. So we're going to theme it, and then we're going to keep it going. We're just going to do it on a monthly basis. But hopefully that will get them that connection that they need when they're really isolating themselves, but they're more willing to come into our practice.
That's very good. Your recommendations to physicians, podiatrists, doctors interested in helping their patients in a lifestyle manner, what would be the first steps you think they should take?
I think my first course, I took the Cornell course, the Campbell course at Cornell on nutrition and food. And that was a good stepping point for me to decide, was it something that I was going to utilize in my practice? Did it fit well? How did I feel about it? Well, my history for me is I've been a vegetarian since I was 21. I am mostly plant-based. I find it very difficult when I go out in public, out in restaurants. It's very hard to eat good quality food out in public on a vegan basis that isn't completely unhealthy. So I started there. After I took that, I decided I was going to go looking for more in-depth training, and that is where I found the American College of Lifestyle Medicine. So that was back in 2000. I got board certified, I think 2019, 2020 on that one. And I said, but before I got there, I realized that I was very deficient. They have their board prep, they have their board review, and I realized there were things that were really lacking. I'll show you, lacking. There we go. I'm going to go grab from my book thing. Okay, this is mine. Okay. Okay. All right. You see, okay, let's zoom in. You get it out. Okay.
I like it.
Okay, this is my book. Okay, right? That's crazy how everything was marked in it for me to have this much when we were going in, you know, the hypertension studies, the PAD studies, the bone density studies. I mean, it's just so much that I felt that, I needed to review, I needed to get better with it. How were we processing it? So that was fairly weighty. And I really want to, I really think my board exam was pretty much this entire book on that one. And that was different from what I had learned in podiatry school. Really, everyone knows, and actually the American College of Lifestyle Medicine has done a much better job about advocating for nutrition to be substantial when it comes to new medical students coming out.
Very good. Well, Jenneffer, I want to thank you so much for joining us on Dean's Chat today, carving time out of your schedule. We will send you a Dean's Chat cup. All of our guests get a Dean's Chat cup.
Woohoo! I'll send you a book.
I would like that. Thank you. I'm going to make some of those delicious recipes. And to all of our listeners out there, if you're listening on Apple or Spotify, please give us a 5-star rating. And of course, if you get a chance, please leave some comments. And if you're watching on YouTube, by all means, become a subscriber. So until we meet again, cheers, everybody.
Cheers.